session is both relevant and educational, and I'm sure it will be beneficial for all of us. It's now my pleasure to introduce today's speaker, Dr.Anila Melody Thomas, MBBS, MS ENT, consultant ENT surgeon, who will be speaking on the topic Basic Concepts about Nasal Bleeding. Nasal bleeding or epistaxis is a common clinical condition encountered in practice, and understanding its basic concept is important for proper evaluation and management. We look forward to gathering valuable insights from today's session. I now invite Dr. Anila Melody Thomas to begin the presentation.
Morning. Today I will be discussing about epistaxis. Epistaxis means bleeding from the nostrils. It's a very common scenario seen in a hospital. The definition is acute hemorrhage from the nostril, nasal cavity or nasopharynx. There are two types of epistaxis. One is anterior epistaxis, the other is posterior epistaxis. Anatomically, any bleeding anterior to the pyriform aperture is known as anterior epistaxis. Any bleeding posterior to the pyriform aperture is known as posterior epistaxis. Usually, children have anterior nasal bleeding. Elderly will have profuse posterior bleeding. Commonly, males are affected more than females, but after the age of 50, both males and females are equally affected. Little's area or Kisselbach's plexus. It is situated in the anteroinferior part of the nasal septum, supplied by both the external and internal carotid arteries. In this area, 4 arteries anastomose, that is anterior ethmoidal, septal branch of superior labial, septal branch of spinopalatal and greater palatine. So that area is very rich in vascular supply. This vascular area gets dried due to the effect of inspiratory current and gets easily traumatized due to frequent nose picking habit in children. Elderly people, the cause is idiopathic, atherosclerotic changes or hypertension. Sometimes the posterior epistaxis, also known as Woodruff's plexus bleeding, the blood can be swallowed up and vomited with a coffee colored color, which will be giving us a misdiagnosis of hematemesis. While taking history, we should look for the site of bleeding, the expectoration of blood, any history of trauma, acute infection, nasal surgery, or usage of drops or sprays, and the duration and amount of bleeding to assess the loss of bleeding, and any syncopal attacks, risk factors like comorbidities like hypertension, non-case of leukemia, hemophilia, purpura, congestive heart failure, renal failure, or liver dysfunctions. If the patient is on any medications like aspirin, NSAIDs, heparin, or any history of taking high dose of vitamin E. Then past history of bleeding and its treatment is very important, because we need to evaluate on detailedly in case of recurrent bleeding. Family history of bleeding tendencies should be asked for to give us a clue about hemophilia. The causes of bleeding include local causes, that is trauma due to the OCD habit of nose picking, maxillofacial, nasal intubation in case of some oral surgeries. Then foreign bodies, live foreign bodies can cause bleeding, and rhinolith. Rhinolith means neglected foreign body, which can form granulation tissues and bleeding occurs. Some infections like rhinosporidiosis, granulomatous diseases like TB, sarcomas, sinusitis, adenoiditis can cause bleeding. The neoplasms can be classified into benign and malignant. Benign causes include hemangioma, inverted papilloma, juvenile nasopharyngeal angiofibroma seen in young males around 14 years of age, aneurysms, encephalocele. Malignant causes include epidermoid carcinoma, adenocarcinoma, sarcoma, and esthesia neuroblastoma or olfactory neuroblastoma, which is a rare presentation causing bleeding, that too unilateral. Then other causes include environmental, like going to high altitude, sudden decompression, drugs like nasal sprays, prolonged usage leading to septal perforations, drops of antihistamines, steroids, and some drug abuses like sniffing cocaine can also cause nasal bleeding. Other septal deformities causing nasal bleeding is a spur touching the lateral wall. In this picture, we can see the nasal spur touching the lateral wall, and as the patient violently sneezes or coughs, bleeding can occur. In winter season, mostly we see bleeding from the nasal cavity due to the spur. Some general causes include hypertension, congestive heart failure, eclampsia of pregnancy, tumors of the mediastinum. Hematopoietic reasons are aplastic anemia, leukemia, thrombocytopenic, and vascular purpura. Some coagulopathies, which are congenital and acquired, bleeding and clotting disorders, multiple myeloma. Nutritional causes can also cause bleeding, like malnutrition, scurvy, vitamin C deficiency, alcohol abuse. In some patients presenting to the casualties or OPD, they give history of alcohol consumption within 24 hours of admission, which will lead to the clotting and bleeding parameters changes, leading to bleeding. Then high dose of vitamin E. Arterial causes include arteriosclerosis, collagen disease, hereditary hemorrhagic thrombocytopenia, liver disease, hepatic cirrhosis, renal causes like chronic nephritis, renal failure, drugs, NSAIDs, ibuprofen and diclofenac, aspirin, heparin, acute infections like influenza, measles, chickenpox, whooping cough, rheumatic fever, dengue fever where platelets are decreased, IMN. So when the patient comes with epistaxis, first we have to look for the vital parameters, the pulse rate, BP, saturation, and then complete ENT examination should be done to rule out any other bleeding. Local examination should be done after clot suction or evacuation with forceps. Endoscopic evaluation to assess the site of bleeding can only be done in less severe cases. In profuse bleeding, even if we do the endoscopy, we cannot localize the point of bleeding. Some blood investigations we do is complete blood count, bleeding time, clotting time, prothrombin time, liver function test and renal function test can be done if there are any comorbidities or alcohol history. Radiological investigations like CT is not an emergency, and we also don't prefer doing CT with the nasal pack in situ. We can do CT after the control of epistaxis. With the nasal pack, we will not get a clear picture on the film. So after 48 hours or once the epistaxis is controlled, we can go for a CT. The treatment is first aid. We all know ice pack application, sitting with back rest. We have to record for the blood loss. Trotter's method means pinch the nose with thumb and index finger for about 5 minutes. And like in the picture, patient should sit and lean forwards, breathe through the mouth and spit any blood coming through the oral cavity to the basin. Ice packs result in stoppage of bleeding by reflex vasoconstriction. The casualty also, when the patient comes, first aid is ice pack. Then we can take the history. With that time, we can evaluate further causes. And after the procedure, we'll go for the nasal packing. Nasal packing, earlier it was done with nasal gauze and bismuth, iodoform, paraffin paste. But nowadays we have a thing called Mirosil, which is polyvinyl acetate, is a compressed form. It is available here. It's a less traumatic way of nasal packing, which can be packed with Tilly's forceps. Like in the picture, we have to pack posteriorly through the floor of the nose, reaching till the nasopharynx. Only when we inject saline into this form, it will get bulged and stop the bleeding. In case of posterior epistaxis, we can also insert the Foley's catheter as seen in the second picture, and 15 ml of saline or water is used for inflation, or in case of any doubtful cases, we can inflate with air also. Medical management for epistaxis. Once the packing is done, we have to give antibiotics, either IV or oral, depending upon the situation of the patient, to prevent any infection, and antihistamines to prevent the sneezing sensation or any allergic symptoms due to the nasal pack. Tranexamic acid is a source of stoppage of bleeding, but the dose should be limited to 1.5 grams TID per day. And it should not be given in cases where there is a pre-existing thromboembolic disease, because it can worsen the situation. And nasal decongestant drops like Otrivin or Botroclone for local stoppage of bleeding. And some cases there will be saturation fall due to the nasal packing, so we have to provide oxygen also. That's because increased pulmonary resistance occurs due to nasopulmonary reflux. And the surgical treatment for this include the electrocautery using bipolar, monopolar or suction cautery under GA or local. Chemical cautery with silver nitrate can only be done in anterior epistaxis. Posteriorly cannot be done. And arterial embolization is a rare phenomena which can only be done in angiography suite. And arterial ligation of external carotid artery, ethmoidal arteries and sphenopalatine artery can be done. Lastly, laser, KTP, NDAG or septodermoplasty in cases of hereditary hemorrhagic telangiectasias or Osler-Weber-Rendu disease, which is an autosomal dominant disease where recurrent epistaxis which is not controlled by any other methods. And some cases like per causing the nasal bleeding, we can do septoplasty or SMR. While doing this, we elevate the mucoperichondrial flap, so it results in fibrosis and a cut in the nasal supply. Blood supply cut varumbo, there will not be any bleeding. Thank you.